Good morning, everybody. Good morning, everybody. I'm being told that we're going to start sharp, so I want to invite everybody to take their seats when you have an opportunity. Well, I think it's about that time. Welcome everybody. It is my distinct pleasure to say hello and celebrate that we're all here at the 12th meeting of the Permanent Council of the Global Alliance for Surgery, Obstetrics, Trauma, and Anesthesia Care, the G4 Alliance. I want to begin by thanking our hosts, the Royal College of Surgeons in Ireland, and also our sponsors, BD, Tech Enable, Meeting Ireland, and FOLTA Ireland. I believe that's the way we pronounce it, right? A big applause and a thank you to them. Dear members of the Global Surgery, Obstetrics, Trauma, and Anesthesia community, welcome to Ireland. And to those of you who are joining us virtually, thank you for taking the time to be with us today. So I stand here very proudly as a member of the G4 Alliance. And yet, I confess to you that the G4 Alliance really should not exist. Because it should be obvious that people should go with care, should go with the dignity bestowed by health. It should be obvious that people should have access to the opportunities that come from having the chance to get safe, timely, and effective SOTA care. But we're here because the ideal has not yet come to fruition. Not in a utopic sense, not in a practical sense, not in any sense that will give us a chance to celebrate any sort of achievement and give us the opportunity to maybe focus on something different. So we come here and we keep on working to advocate for the neglected surgical patient. And we do so with passion, with energy, with enthusiasm, with substance and determination. It is too well known to us that members of the SOTA community around the world have gone for decades trying to serve the needs of communities, and have been left to heroics. Most importantly, it is too well known that members in communities around the world have gone for too long without access, have gone for too long without opportunity, have gone on for too long without hope, but we want to change that. I remember the very first time I was encountered with the face of hopelessness. As a 16-year-old kid in my hometown of David, Panama, I showed up to translate for a group that was going to come in to take care of children with cleft conditions. Lined up in the hallways of the regional hospital in David, hundreds of children with cleft lips and palates, prepared to get some sort of treatment, some sort of help. They couldn't smile. And I learned then that they couldn't eat, they couldn't speak, they were bullied, they were hidden, they were forgotten. And in looking at the side eyes of the children, I also looked around and saw the sad eyes of the mothers. See, in the high-income countries, within 24 hours of a child with a cleft condition being born, children are referred to a craniofacial institution for treatment. So I asked a question. Why is it that these children had not gotten treatment? Why is it that these children had gone on without care, without hope? Many of you know that the last fistula hospital in the United States closed its doors in 1894. And instead of the hospital, the luxurious Waldorf Astoria was built. This is more than a century ago. So how is it that women, millions of women, still have to suffer from a condition that has a solution? So the question is, where is the justice in that? A few months ago, a really good friend of mine and one of the most brilliant minds I know had a terrible accident on his way to a capital city. And as I look at the picture and he tells me this story, I realize that he escaped what could have been a terrible destiny. But laying on the side of the road, still surviving, he lay there with a fractured femur. A good Samaritan picked him up and drove him 2 hours to the central hospital. It was a Friday night. There was no surgery for him until Monday. Maybe. In his early 30s. So I asked the question, how about his suffering? And how about his future? So because the questions still remain, the work must remain. And this is what brings us together. But I don't want to look only at the glass half full. As yesterday was a great day. The working groups of the G4 Alliance met, and as our dear friend Serena was saying when some of us walk into the advocacy working group, there's a world of opportunity. There is so much we can do. And we ended the day with students. And what a way to end the day. Because the students inspire us. And they remind us that they are willing to join us and take on the responsibilities of those goals we're yet to achieve. So today, we come together to do more work, to exchange, to share, and to collaborate. Because the world of health for everybody deserves the kindness, talents, and attentions of everybody. So I'm going to give you a sneak peek at today. Here's the agenda. We're going to have a really full day of discussions and presentations with the panelists. I want to show my gratitude to the working group that worked for months to prepare for this meeting. So our PC Planning Committee, chaired by Dr. Richard Henker and Professor Rari Bruga. Thank you so much for giving us the chance to be here today. And yes, absolutely. As so many of us say when we get to work towards these meetings, we get the band back together. But it was great to be with Professor Henker and Professor Bruga leading the way. I have a few reminders. For those of you who are joining us virtually, remember there's a chat and QA features on the webinar version. We want you to know that today is not only about exchanging, listening. We do want to draw some lessons and conclusions and end up with a statement that will continue to advance our growth as an alliance and push for our work. We want to ask you to please join us on social media, share the messages, share the thoughts, share the good news, share the challenges, look for the solutions, and advance the message well beyond the confines of this room or wherever you are joining us from in the different parts of the world. So that's probably enough for me to help us get started. I really do want to say thank you to Professor Bruga for his leadership. Yesterday, he shared with us his story and how he came to be a member of the global surgery, obstetric trauma and anesthesia community. He's someone who's engaged in offering care to some of the neediest communities in the world, a source of inspiration, and someone who said at some point, I can't really seem to get out of this. I love what I'm doing in SOTA care, so we're not going to allow you to for a lot longer than you even want to. Professor Bruga, thank you so much for your leadership as part of the Royal College of Surgeons in Ireland and for your leadership in the global surgery community. Please welcome welcome to the podium, and we look forward to hearing from you.
So thank you, Ruben. I didn't warn Deirdre beforehand that I was going to go off script. I have my script to welcome people. I think we have a couple of minutes. And I'd like to first start by just acknowledging my colleagues in the G4 Alliance who have organized this meeting. And listening to Ruben there, I think you would agree with me that Ruben is the big heart within the G4 community that have put this together, and Dan is there as the brains on top of all the detail. I wanted to actually start by just acknowledging the absence of Professor Cathal Kelly and Professor Hannah McGee, our CEO and Dean. It is a very close family death in that case. Yet they are hugely committed to the field of, we used to call it global surgery. I've now learned over the last couple of months, we really should be talking about SOTA. So here's maybe my first and only suggestion. Could we start calling it SOTAN, which sounds rather like a soutane or something a priest might wear? Because the nursing is as important as all the other specialties. And it's great that we've had that commitment. So, as well as thanking Ruben, Dan, Rick, and the others, I'd like to, often the thanks come at the end of the meeting, but I won't be talking this evening, so I'd like to give a special recognition to Deirdre and Fergal for all they've done to put this together. And if anything goes wrong, it'll be those of us who are up here who have somehow messed up. I thought I might just say something about RCSI, because I'm sure Professor Cathal Kelly or Professor Hannah McGee would have said that. It was founded in 1784. It's one of the three main royal colleges. But along the way, in parallel to the training of surgeons, it became a medical school. And when I came here in 2005, I was doing kind of health systems research. I used to go off to Africa, and people would scratch their head and say, but what's this got to do with surgery? Surgery has come full circle now in RCSI in a special way, and that is in the area of the global dimension of it. It started with the COSEXA collaboration, which was launched in 2007, and I was involved with that from the beginning. And then with our research, our Cost Africa and Surge Africa work, which started in 2011. But there's a perception in Ireland, I had it before I ever came here, that RCSI trains the rich kids. And indeed, only 20% of our medical students are from Ireland, a very high proportion from the Middle East, from Malaysia, as we learned last night, and from North America. And we're actually very proud of that. But when I was preparing my inaugural back in about 2006, 2007, I went back to the original roll books where the graduates' names were entered, where they signed in to the roll books in the 19th century. And a very high proportion of the doctors that we qualified were from Africa. So this is very much a coming full circle. There is a huge commitment from the college, which has come in the way of our own funding for the Institute of Global Surgery. And we'd also like to thank the Dennis O'Brien, the Iris O'Brien Foundation, for its funding of our Institute of Global Surgery. So now I go back on script, and that is to, well, I've been introduced already. I'd like to thank the G4 for allowing us host this. It wasn't a given when we started discussing it 6 or 7 months ago. And in fact, there is a very justifiable call for saying the next in-person meeting should be in a low, middle income country. So we are honoured that you actually allowed us have this first full meeting. I haven't been at a meeting like this in 2.5, 3 years ago. Dan's going to be pulling me away from the lectern any minute now because I have an audience. But I'd also like to thank those I haven't mentioned so far, the G4 Board of Directors and other distinguished organisations that are here today. You're going to hear some wonderful speakers, some of them in person, some of them remote. I'm actually not going to name them because you will be hearing them during the day. And I think it's more important that I do, as Ruben touched on there, which is to acknowledge our sponsors. So that's BD, Tech Enable, and Foilta Ireland. So BD and Tech Enable are both current partners of ours in the Institute of Global Surgery, and you'll be hearing more about them during the day. You'll be hearing from some of the presentations about our Kids Surge initiative. It's a follow-on to Surge Africa. It's about delivering surgical care to children right down at the district hospital level, which BD has been funding. And Patrick Ferris, the BD Sales Director, will be there at the Collaboration Cafe today. You'll also be hearing from Tech Enable's Technical Director, Peter Rose, in the last panel session today. So on behalf of RCSI, I want to thank everybody who've made the effort to come here. We really hope you enjoy Dublin. Unseasonably warm and windy at the moment. And at this point, I'd like to introduce somebody who, again, unfortunately cannot be here, which is our Minister of State for Overseas Development Aid and Diaspora. He's the Honorary Colm Brophy, TD, who's at the COP27 as we speak. So surgery is in there with these other global priorities at the moment. So at this point, I think we're going to hear from Minister Brophy on a video address that he's made for us. So at this point, I'll sit down. I think Ruben's going to take over, and I just wish us all a really good, productive meeting that will energize us as we go away from here to bring that much-needed, essential surgical obstetric trauma, anaesthesia and nursing care to neglected populations worldwide. Thank you.
Good morning, everyone. It's a great pleasure to welcome to Ireland the Permanent Council members, the Board of Directors, guests and executive staff of G4 Alliance for Surgical, Obstetric, Trauma and Anaesthesia Care. I'd also like to welcome those joining the meeting online. This is a truly international audience, and I'm delighted to be welcoming delegates from Africa, Asia, the Americas and Europe, and of course those of you who are based in Ireland. As human beings, our own health and the health of our family and friends and community is important. Regardless of age, gender or background, health is our most basic asset. For societies to function and thrive, we need to be healthy and to have access to the right care, including surgical care, when we need it. The right to health is fundamental to our human rights. The importance of health and well-being is well recognised in the Sustainable Development Goals, and specifically in Goal 3, to ensure healthy lives and promote well-being for all, at all ages. Ireland, along with Kenya, co-facilitated the adoption of the SDGs, and we're deeply committed to attaining these goals domestically and internationally. With just 8 years left until 2030, more than 5 billion people still do not have access to adequate standards of surgical care. This is unacceptable and is a situation that requires sustained advocacy. So I applaud the G4 Alliance for taking up the mandate to advocate on behalf of those furthest behind for a stronger, more resilient health systems that can deliver access to safe surgery for all. The universal nature of the SDGs is key, and our development cooperation programme is firmly rooted in the need to ensure the needs of the furthest behind are met. Working with partners, including the Royal College of Surgeons in Ireland and the College of Surgeons of East, South and Central Africa, we are committed to playing our part in the effort to reach people living in resource-poor contexts who lack access to safe, affordable and timely surgical care. As it enters its 15th year, this unique global health partnership, which we are very proud, has expanded beyond surgery to encompass other dimensions of SOTA care, including anaesthesia, perioperative nursing and obstetrics workforce training. For over 10 years, the RCSI has been a leader in researching and implementing evidence-based solutions for better surgical systems in parts of sub-Saharan Africa. With funding from the European Union, researchers have demonstrated how the right support and supervision for non-doctors can enable them to safely deliver essential surgery in remote and under-resourced settings. This is one of a number of examples of what can be done to ensure that no one gets left behind. In 2021, I was delighted to launch the RCSI's Institute of Global Surgery. The Institute has built on a proven track record in providing training for surgery with a focus on underserved populations. Since its launch, the Institute has taken on several new projects, including those which will have a direct impact on women's health. While in the RCSI, you should look out for a portrait of Sister Dr. Maura Lynch, who revolutionised obstetric fistula care in Uganda. Her commitment to training future generations has ensured that even after her death, the Kitovu Hospital in southern Uganda continues to treat and cure women affected by this surgical condition. Partnership has always been at the centre of Ireland's development cooperation, and it's at the heart of the SDGs. Partnership is central to all of the RCSI's global surgery projects, and I see that theme of partnership runs throughout today's programme. Good partnerships are equitable partnerships, and I welcome the emphasis on equity and the diversity of speakers and moderators, as well as the cutting-edge mix of issues that you will discuss today. It's with great regret that I cannot join you today, but I trust you will have a fruitful meeting. I commend you and wish you every success in your efforts to ensure that safe, essential surgery can rapidly be offered to all those who need it, especially those in resource-poor settings. Thank you.
Okay, we'll move on to the next piece of this session, and Dr. John Sampson is going to go ahead and moderate 4 different groups, and they're going to be looking at innovations in terms of SOTA care. And let me just briefly introduce Dr. Sampson. Dr. Sampson's Associate Professor in Anesthesiology and Critical Care at Johns Hopkins School of Nursing. He serves as Director of Anesthesia for Johns Hopkins Global Surgical Initiatives Collaboration for Surgery, Obstetrics, Anesthesiology, and Public Health. It's always a pleasure to talk to Dr. Sampson about the anesthesia work and the training of nurse anesthetists he does in places such as Sierra Leone. So at this time, I'd like to hand this off to Dr. Sampson and have him go ahead and introduce his panel. Dr. Sampson.
Good morning. All right, so today we'll be talking about technological innovations related to global surgical, obstetric, trauma, and anesthesia care. And we'll be including 3 other presenters with our program. We'll be including Beth Kokolo, who's the founder and president of Shift Labs, which has innovated a global health technological solution. Tim Goodwin from another company called Sisu Global will be featuring his, and Dr. Ganadraj, who is not able to join us today. He's actually going to be presenting remotely from India. All right. So, let me see. So my name is John Sampson. I'm an associate professor of anesthesiology and critical care medicine at Johns Hopkins University and head of one of the global health, global surgical anesthesia programs there called the Global Alliance of Perioperative Professionals. And this area of technological innovations in global health is very important to me because I've actually worked in a lot of different international settings, and sometimes you feel frustrated that you're not able to provide the same type of care that you could if you were here practicing where you're comfortable with. And some of those problems are because of technology that simply isn't available, but should be, could be, or technological solutions that could be implemented, but because the large corporations don't see economic value in that particular innovation, it is not applied to that particular location. So I'm very happy to see that BD is actually sponsoring this particular program here, and hopefully that will represent one step towards changing. So in terms of some of the objectives, today we're going to define just the problem of global medical devices and global SOTA care, identify problems of technological mismatch, review some barriers to technological innovations in low-income countries, and also to identify how it impacts patient care and physician nursing working conditions. And then, of course, highlight some great examples with the other people on our panel. Okay, so there is a difference between technology and its application in low-income countries and high-income countries, some of which I've already alluded to. The overwhelming number of medical device manufacturers develop for Western applications, and they really don't even, I think in many cases, they don't even think about how they might modify their sales models for lower income countries and actually be able to still make a profit that makes it worthwhile for them. One of the ways that we at the G4 Alliance can influence that is by helping to assemble ministries of health so that the purchases that are made are bulk purchases and rather than them looking at very small purchases. But thought needs to be placed into this issue. Many devices are also not designed to meet the environmental needs of lower resource countries, resulting in technological mismatch. This is just a graph of recent medical equipment sales globally, and you see that Latin America, it was so small they actually folded it in with the Americas, and the Middle East with Africa combined was only 2.3%. One of the things that's needed is advocacy. Without advocacy, you have companies that actually create a solution that's very valuable to a lower resource environment and then scrap that solution completely because they come up with another solution that is more amenable to profit in the high-income area, and they don't want the high-income area to have access to the lower-cost solution that was before them. This is actually an example. This company actually made a great simulator for training. And this simulator, when I was starting training for teaching people in low-resource areas how to use a mechanical ventilator, we found that even our multi-million-dollar simulation lab at Johns Hopkins didn't have a mannequin or model where the model self-breathed actual tidal volumes. And so we actually found this low-cost solution that a company made for automatically breathing lung connected to a mannequin where we could literally simulate actual breathing and interaction between a person breathing and a ventilator. And this model was great. We've used it in multiple countries, from Tanzania to Sierra Leone and other locations, but the company who manufactured it came up with another solution that was 10 to 15 times more expensive, required a complicated computer interface, but actually could give some higher fidelity and therefore scrapped the initial application that was available that was very effective for teaching people in lower resource environments because they didn't want it to be available, for those in the higher income locations. So those are areas where we can advocate. Another area where we need to advocate is actually to identify priority issues that need to be solved. And one of those that affects people throughout all countries is the access of medical records. If you don't have a record of what's happened to a patient later, it creates a big problem. And on the top, you see an example of an actual picture that I took of a medical record department in one of the places I work with. And in this location, one of the workers was tasked to clear out this room so they could put more medical records there. So they, since they realized that nobody was ever looking at those medical records, they innovated a very creative solution. They burnt all of the medical records so that there would be more room for medical records to come in later. Their supervisor was very angry at them, but in actuality, they solved the problem that he presented to them without any adverse consequence because nobody looked at the medical records anyway. So medical record solutions can be pursued, not necessarily the medical record solutions that we use. I believe that the Johns Hopkins contract probably for the EPIC system is somewhere in the order of $1 billion, just for the medical record system. I don't think that there are many low-income countries that can afford a $1 billion medical record solution, but neither do their solutions need to have all of the bells and whistles that we use here, we use in the United States and Europe. They need to have basic functions of being able to re-access medical files of a patient, and those can be borne out with lower cost solutions. So some of the categories of technological solutions I think is important to delineate. I view the G4 Alliance as having dual missions. One of the missions is, like Dr. Ayala said, to help to bring access to people who don't have access to different surgical procedures, such as cleft lip. And that's very critical wherever they are, no matter what country they are in and everything like that. And when we look at the countries or the Ministry of Health and we generalize them all to be very similar, maybe there's a similar approach in terms of that. And that's where number one comes, technological innovations for Westerners in low-middle income countries. That's also very important for the Westerners who are coming in temporarily and working in those countries. They need to have a way of bridging the gap so that they can function. But I also think it's equally important to identify countries that have the potential of self-sufficiency in terms of global surgical obstetric trauma care and global health in general. And we need to identify those shining examples and empower them so that they don't actually need our help. And I think that's another issue that we need to address in terms of what we're doing globally. And that's where number two comes in. Technological innovations for clinicians who are working in these environments 365 days a year, their entire career. And so we need to have solutions that are for them, and the solution number one and two, they're not actually the same. And I'll demonstrate in just a few moments. Number three, there are digital-based innovations that involve telehealth, internet, and cellular phone-based solutions. And then there are innovations for learning, which are also important. And then number five, I believe that medical record innovations is so important that it stands alone as another thing that we need to address. Okay, medical devices in developing countries, perception versus reality. Perceptions on the left. We see all of these wonderful things and we fantasize about all of the great technology that we can offer to low-resource countries, and we facilitate getting those things to them, except then the error code happens when we plug it into the unstable electrical grid, and we result in reality number two. On the right, that is an actual picture of a medical equipment graveyard. This is what is happening to much of our medical equipment. It is ending up as junk. It's ending up as junk because of issues of power, stability of power failures, power surges, used equipment, new equipment that doesn't meet the right specifications or the conditions of the environment. All of these things results in reality number two, medical junk, and it's upon us to figure out how to overcome that. An example would be this anesthesia machine, wonderful looking anesthesia machine. At the time that it was purchased by this country, it was similar to the same anesthesia machine that would be used in the United States. Bells and whistles, everything, never used once. I found it in a developing country, and it had never even been used on one single patient. In fact, I will tell you that the plastic covering that protects the LCD screen has never been removed. It's never had a drop of soda lime placed in it. It's never been used. It is sitting there, and here at another hospital in the same country are two other anesthesia machines, also purchased, brand new, never been used. Why have they never been used? Number one, the empty soda lime containers are an example. Soda lime is an essential thing for anesthesia care with a general anesthesia machine because it absorbs the carbon dioxide and prevents you from rebreathing carbon dioxide and becoming acidemic. Very essential. But if you don't have a supply chain for carbon dioxide granules, that presents a problem. These machines require stable electricity and don't really work at all when the power goes out. If your power goes out routinely every day, and sometimes for long periods of time, that's not going to work. They require compressed oxygen. If a compressed oxygen tank or supply of continuous oxygen availability is a rare commodity, those machines will be completely useless. Finally, those machines require continuous maintenance and technical support, usually provided and facilitated by the company itself, and the companies are not going to go over to Africa to actually service these machines, and therefore rendering them as useless, expensive pieces of junk. Fortunately, two companies, one in England and one in the United States, endeavored to solve this problem by creating an anesthesia machine that actually overcame each one of those technological challenges, overcoming the power outage thing, not requiring any soda lime, and the machine actually produces its own electricity with an integrated high-capacity oxygen concentrator. This is the Gradient Universal Anesthesia Machine, which is one solution, and the Gloucester vent out of England, which is another solution, was actually the first solution to this particular problem. So both of those are solutions to overcome these, but here's a commonality between those two companies. Both of those two companies are small companies. The large companies could have created a solution at any time, but they chose not to because it wasn't in their economic interests. If you don't have bodies like this pushing the envelope, then we're not going to change that paradigm. These are examples of technological innovations for Westerners temporarily in low-resource environments, like I mentioned before. Not only are nonprofit organizations interested in those solutions, but the military as well. On the left, you actually have a mobile operating room. In other words, the operating room is just over the portion of the patient that you need to operate on. Isn't that interesting? And the military has innovated that, along with larger mobile operating rooms that the whole team can be inside of. These are also mobile operating units that basically can be transported in huge giant planes, and the United States military can unfold and blow up these things within literally under an hour. They have an operating room. This is not practical for people who live in the environments, but they are useful for people traversing the environments, not just for military operations, but even the military does medical missions. And so they're useful for providing needed care in locations where the system just can't be developed, not necessarily for places that have the potential, which another longer-term solution may be more impactful for actually improving the healthcare system of the location that you're in. So one of the things that we're going to do here with the Technological Innovation Working Group is in-person events, virtual events to highlight some of these innovations. Like today would be an example of both a virtual and in-person event. And these will be used to disseminate the information needed to different locations, advocacy, and then finally we hope to have some competitions for needed priorities like medical records that can be deployed. So now we're going to actually feature one of our first innovations. This innovation will be presented by Dr. Ganaraj, who identified the problems for doing laparoscopic surgery in low-resistance environments. As most of you know, laparoscopic surgery is very useful because it has less postoperative pain, less bleeding, it's less, the person can recover very quickly from a laparoscopic surgery as compared to an open surgery. However, it does require carbon dioxide compressed gas tanks. Remember what I already said. These locations, some of them have problems, big problems, with oxygen availability in oxygen tanks. So now I need a surgical technique where you need compressed carbon dioxide. But not just that, the anesthesia team needs to be able to measure that carbon dioxide in the patient's body, and a lot of those locations don't have capnography. And there's other physiological changes that happen during laparoscopic surgery that anesthesia needs to advance to be able to deal with. So now we're going to listen to Dr. Ganajaraj. I'll pause just for a second. Maybe you can get the audio on him. I'll go back and see if we can. Just let me know when you got the audio. Go? Okay.
It is important for surgical patients in rural and remote areas to get back to work as soon as possible. Minimally invasive surgeries, like laparoscopy surgeries, make this possible. However, the high cost, the logistic nightmare of providing gases for both anesthesia and surgery, and finding us in anesthesiologists in rural areas means that laparoscopy surgeries are not available to 90% of the rural population who need them. The most important step to provide laparoscopic surgeries in rural areas starts with making laparoscopic surgeries possible under the easily available and low-cost spinal anesthesia. The gas insufflation plus laparoscopy surgeries, GILS in short, makes this possible under spinal anesthesia. Laparoscopic surgeries are carried out by passing instruments through small incisions and looking inside the abdomen using a telescope and camera. The insufflation of gas distances the abdomen and makes space for using the instruments to carry out the surgeries. The gas also pushes away the intestines that come in the way. Unfortunately, the gas increases abdominal pressure and also gets absorbed. These cause physiological changes that calls for experienced anesthesiologists to manage. The GILS surgeries are performed using special equipment to lift the abdominal wall so that necessary space could be created to carry out the surgical procedures. And the positioning of the patient uses gravity to move the intestines away from the surgical field.
And that is the time we came up with the gas insufflation-less laparoscopic surgeries. It is possible to do them under spinal anesthesia. It does not cause any of the physiological changes, so it is safer. Especially the difference between cost between general and spinal anesthesia is huge. The hospital stay is very short, so the turnover is very high. So more number of surgeries are possible within a shorter time, which both facilitates learning as well as caters to more number of surgical patients.
So Dr. Ganajaraj is very innovative. He's actually created a whole team around him and actually has innovated one particular technique for doing laparoscopic surgery without any CO2 gas, without any gas at all, by having this contraption where he actually elevates the abdominal cavity from a device inside of the abdominal cavity itself. And therefore, eliminating the need for the CO2 tanks, eliminating the need for some of the pressure effects on the patient. And then in the United States, we would never actually do laparoscopic surgery. Generally, we never do it with a spinal anesthesia because there are too many risk factors related to the effects of the CO2 that we're insufflating, but they can actually do this reliably with spinal anesthesia in this case. So that's Dr. Ganadraj's innovation from England. Next, one of the things that is a challenge when you're working in a low-resource environment, and it's for people who work there all the time, they don't even consider it a challenge because it's just an everyday routine, relates to the IV infusions. This came very much so as an issue with the COVID epidemic because you needed IV infusions not only of fluids at a certain rate, but of sedative medications, of dopamine infusions, epinephrine, norepinephrine infusions. You needed critical infusions that go at a precise rate. And what's normally done is they just count the drops and calculate from counting the drops what the cc's per hour is. And it's a little bit laborious, and it's prone to different errors that can occur from person to person. So the question is, why don't they have IV infusion pumps in these areas? Well, there's a number of reasons, one of which is that the IV infusion pumps are expensive. The other thing is that they have high maintenance needs. This is people in our area that are actually maintaining. We have a whole team of people that do nothing but take apart and reassemble and fix IV infusion pumps. The batteries in these infusion pumps have a tendency to basically expand over time, so they will get bigger, and if they're abused too much, they can actually cause damage, explode. We generally change every battery in our hospital within 2 years. And so there are a number of technical issues that make it so that you can have an 800 or 900 hospital at Lagos University Teaching Hospital or any other place where they may only have a very few IV infusion pumps. And so next we're going to have Ms. Beth, actually it's Dr. Beth Koklo, who's going to be here talking a little bit about her innovation that is currently being implemented in multiple locations around the world for overcoming the challenge of providing care with IV infusion pumps.
Thank you, Dr. Sampson. So I'm going to talk for about 5 minutes, and I'm going to talk about Shift Labs. So I am the co-founder of this company. We started about 10 years ago, but I have 2 other jobs, which are relevant to my comments today. So I'm also a professor of human-centered design and engineering. Thank you. Very short. At the University of Washington in Seattle, where I'm also associate department chair. And that role, I've been a professor for about 30 years, that role informed my sort of desire to start this company about a decade ago. The other job that I have is in venture capital, and I started doing that about 4 years ago as a result of having started the company and working with some of my investors. And that work within venture capital has given me, I would say, a whole other perspective on some of these challenges in terms of developing innovative products that meet the needs of patients in low and middle income countries. So with that, I will start with, okay, so I think you're going to hear the phrase human-centered design, certainly from my colleague who's going to come after me, becomes a buzzword. This is what I am. My department is called human-centered design. It's a great way of sort of taking our original assumptions and then thinking about how do we build better processes and products. And one of the things that we did at Shift Labs is we said, okay, let's take a human-centered design perspective and figure out what kinds of products are really going to help move the needle in low and middle income countries. As a professor, I had been doing a bunch of research in mostly sub-Saharan Africa, some South Asia, within the healthcare space that motivated these questions. So things like looking at the context of use, not just hospitals, but homes and all kinds of clinics, but also meeting both with patients and providers and thinking about what kind of design innovation do we need. So that's really great. Design innovation helps us build meaningful products, but it's actually not enough. But let's talk about design innovation for a little bit. What we did at Shift Labs was we talked to a lot of doctors and nurses, and we just said, hey, what's hard about your life? We didn't start with a certain, we were non-experts, right? We were not clinicians. We didn't start with, let's think about pediatric care or maternal care or malaria. We just said, what's hard? And the one thing that everyone said was hard was administering medications intravenously, because most people don't have access to infusion pumps. Honestly, if you look globally, most people, most patients get medications without pumps. And so what that means is people are using gravity infusion to deliver medication. Gravity infusion is notoriously inaccurate and changeable. This is an image that shows some of the factors that can affect drip rate. And so people are counting drops. It's incredibly laborious and it's not very effective. And we have lots of research to show us the ineffectiveness of it. Unfortunately, basically you have two choices. If you want to deliver IV medication, you either use pumps, and Dr. Sampson just saved me about a minute and a half of talking about all the reasons why pumps are a bad idea, or you have unmonitored gravity infusion. So we said, okay, how do we fix this problem? And what came out of that is, I think, some successes and also some failures, although my colleague Chia Kawahara over there says that I should not talk about failures, but rather opportunities for collaboration. But we're going to start with some of the successes. So we built it. We built a product. So it's in my pocket. It's very small, 3.8 ounces. It's been on the market for years. It's FDA cleared. It was CE marked. We dropped the CE mark last year because it was so expensive to maintain. That's one of the opportunities. Super simple interface, almost no language, so you don't have to translate. No sub-menus. Training takes about 5 minutes. Like, all of these things were incredibly methodical in terms of how we designed it. It's very accurate. It's got an optional alert. It'll run off 1 AA battery. And so we've got, let's see, this is from Haiti, a bunch of maternal health clinics. This is a hospital in Chinamoyo in Zimbabwe, where Chia went and helped deploy it there. We've worked with the US military, who have similar kinds of challenges, particularly around dirty power, burning out the motors of their devices. This is actually, let me go back a second. There's a nice article in the AANA journal, a case study of using the drip assist to administer a broad variety of medications when the pumps were not available. Anyway, so these are all the successes slides, right? I like to show these pictures of happy customers. We were big in Ebola, so we had both MSF and WHO use the product in Ebola treatment units. And then we also ended up finding a bunch of customers in the US. They actually found us because it turns out if you build affordable devices, they are useful around the world, which is great in the short term, certainly. The idea of a simpler technology helping both patients and reduce healthcare system costs is ubiquitous. And I think that's sort of one of the big messages that we try to carry forward from the work that we've done at Shift Labs. This isn't just about building a separate class of products for low and middle income countries. I passionately believe that we can have high quality products that improve healthcare costs across the globe. There's no reason we need to differentiate the products themselves. Particularly in the US, as well as in Europe, when you start moving outside of high acute care environments, whether it's outpatient care or home care, you need to have the same kind of flexibility, reduced training costs, different options in terms of power. Our device runs, for example, off of 1 AA battery. While from a technological development perspective, you can have that global market, what becomes more complex, though, is the sales, the marketing, the outreach, the driving awareness. And so if I were going to talk about, this is a clinical study that we did in Kenya around maternal health, showed that the drip assist we proved that it will reduce the side effects from medication. This was around magnesium sulfate. This is a study that's a manuscript that's in preparation. These were some researchers at a military medical school. If you read the table, you can see the dramatic reduction in error rates once you use the drip assist. So it seems like, hey, that's great. So now we'll talk about the opportunities. And this is really where that venture capital experience of the last 4 years provides an additional perspective. There are real structural reasons why a company like BD isn't selling a whole host of equipment into low and middle income countries. And those structural issues, I think, can be reframed as opportunities for collaboration with an organization like the G4. Obviously, I'm not going to go into that in detail. I'm happy to continue this conversation at another time. But you have small companies like ours, like SISU, you have large companies. We're all facing the same kind of barriers to growth and substantive outreach in low and middle income countries. And I would sort of boil this down into 3 areas for potential collaboration. And the first is around thinking about key opinion leaders and ways to engage around policy advocacy for certain kinds of technological interventions. The second is how do we integrate new products into training regimes to drive awareness for clinicians in country. And the third is thinking about regulatory standards, manufacturing quality, and ensuring that adhering to those international standards is primary, because we cannot have health equity if we are not producing high quality devices for all patients. So thank you very much.
And so her device actually bridges that barrier between Westerners who are traversing and doing medical projects in low-resource countries. And I think that a lot of the customers are actually that category, whereas the product can actually be extremely valuable in improving the working conditions and the quality of care for practitioners who actually live in those countries, working in major, large teaching hospitals that have hardly any IV infusion pumps. Those are areas where her product can have major impact, but many of those practitioners are completely unaware that this product actually exists, and that's one of the things that we can do. So the next area is in terms of Cell Saver. In the United States and Europe, we use Cell Saver routinely for surgeries that have large amounts of blood loss. It allows us to extend our blood supply, to use less donor blood. In low-resource countries, many times getting donor blood is actually a big challenge because of many reasons, including cultural reasons. In addition to that, the Cell Saver machine that you see listed here will at least cost $20,000 to $30,000, if not more, and that doesn't include the disposables, that doesn't include the technical support for setting it up, that doesn't include the maintenance issues, a lot of issues that prevent this thing from being deployed. I've actually seen some situations where a hospital in Ghana, for example, has purchased one of these, or in one of Nigeria has purchased one of these, and they actually can describe that it becomes an albatross, it becomes a very difficult thing to maintain. And yet, one of our partners has innovated an interesting technical solution to this. Their company is called SISU Global, and so I'm introducing Tim Goodwin from SISU Global.
Good morning, everyone. To those of us who are joining us online, good afternoon, good evening, or maybe even a very early good morning. My name is Tim Goodwin. I work with SISU Global, and I'm here to talk to you a little bit about the Hemofuse. Like Dr. Sampson said, Hemofuse is a device that performs whole blood intraoperative auto transfusion. So just to start, I want to ask the question of the audience. We have a lot of healthcare workers here, and if you could just raise your hand if you've ever been in a situation where you've been operating and you've reached for or called for a unit of donor blood and it's not been available. I'm just wondering how many people in the room have had that experience. Yeah, I see. Yeah. Yep. And that is not an uncommon experience, unfortunately, especially in lower and middle income countries. According to the WHO report on global blood availability and safety, there is a total unmet need of about 100 million units of donor blood per year. And these were stats that were provided before COVID. One of the many knock-on effects of the COVID pandemic has been a great reduction in the donor blood supply globally. I don't know how many of you in the US, and I live in the UK, I'm a big football fan, and nowadays I watch football and every commercial break is the NHS putting out an urgent call for blood. What happens when you don't have donor blood? Well, oftentimes, doctors have to cancel or delay non-emergent surgeries, resulting in an even increasing further surgical backlog. In really desperate situations, where it's an emergent surgery that can't wait, they have to do what they can do using methods such as scoop and sieve that have saved millions and millions of lives, or simply transfusing fluids and hoping. Now, like Dr. Sampson referenced, the cell saver and intraoperative autotransfusion is a standard of care, standard practice in high-income countries, but for some of the reasons he listed, including the cost, the technical requirements, and the need for a specially trained perfusionist, it's not the standard of practice or very often practice in LMICs. So again, here we go with that buzzword, human-centered design. The inventor of Hemofuse worked with Ghanaian clinicians and healthcare workers and engineers to figure out a solution to provide a sustainable and affordable option to perform whole blood intraoperative autotransfusion. Some of the needs that were identified during this process might seem obvious, but they are: for the patients, they need timely access to blood products to survive. For surgical teams, they need an option to provide autotransfusion that they can quickly assemble, they can easily use, and can be used by the surgical team that is currently in the room. And what do the hospitals need? Well, they need an affordable option. They need to ease their demand on donor blood by allowing their donor blood to go further, and they need to perform more surgical operations. So this is where I come in. I'm not an engineer. If you have engineering questions about the device, I will happily introduce you to the inventor. Where I come in was on the implementation and the training side. So when we launched in Kenya, we cast a wide net for stakeholder engagement, working with surgical teams, hospital administrators, government bodies, the local medical organizations, and even NGOs. The goal? Make Hemofuse and autotransfusion the standard of care in applicable surgical operations. So how did we do that? Well, the first was by building knowledge, and that was done through a fully and robustly developed training program. We've now supplemented that training program with courses that are available even via WhatsApp, which we have found is a method of communication that is easily at people's fingertips, and they can spend 5 minutes here, 5 minutes there, doing that course online to keep their skills sharp. We supplement that with classroom learning, as well as simulation training. In the interactive cafe today, you can come by, and I have our training simulator that we use to train in hospitals, and you can feel free to come try it out, test your skills, and see how we do training in our hospitals. How do we build that confidence after that initial training? Well, we rely on the identification of Hemofuse champions. These are healthcare workers, surgical team members who are really, really passionate about blood transfusion and providing the best possible care for their patients. So we've identified these champions, provide some extra training so they can know how to troubleshoot and help build the practice in the train-the-trainer model for their fellow healthcare workers and surgical team members. And they are our eyes and ears on the ground sometimes to help us keep track of what's going right, where they need some additional assistance, and how we can lead to the final goal and the satisfaction, which is blood being transfused back to those patients immediately during surgery. Now, I just want to focus here on what have we seen as sort of the 3 core significant benefits that Hemofuse has been able to provide. The first, for the patients, and this one's pretty straightforward, it saves their lives. One of the doctors in Kenya who I work with works in a remote hospital. He has a catchment area that treats 3 million people, and he has 2 hospitals that provide surgical operations. So for him, having an option for blood transfusion that is immediately available has had a massive impact for him and his patients. So for patients, they've had better outcomes, faster recovery times, a lower risk of transfusion-related reactions and complications. And the other knock-on effect is it does ease the burden on patient families. Oftentimes, when a patient comes in who needs urgent blood transfusion, families are called upon to come in and donate blood in a replacement donor system to refill the blood bank hole that has been left by their family member needing urgent blood transfusion. At the hospital level, both talking about the surgical teams and the individual hospital, we have seen that they've been able to greatly reduce the number of canceled or delayed operations, and they're able to provide the highest quality of blood transfusion for their patient, which is the patient's own blood and whole blood containing plasma, platelets, clotting factors, etc. What we replicate in Western countries with component therapy, they're able to do with the whole blood then and there. One specific example I want to highlight is at a mission hospital in Nairobi, where this is one of the first cases I saw. A patient with a ruptured ectopic pregnancy came in urgent need of donor blood. The surgical team called down to the lab, requested 2 units of donor blood, but the surgical team also identified this was a hemofused patient. They called us, we showed up to the hospital as they were prepping. We were able to support the team, make sure they felt confident to perform the operation with hemofuse, and they were able to collect and start transfusing 2 units of fresh whole blood, complete the surgery, and be closing up the patient before that donor blood had even arrived from the lab. When that donor blood arrived from the lab, they said, thanks, but no thanks, you can have this back. We don't need it, and they were able to save that blood to be made available for another patient. Which leads me to the blood ecosystem and the greater treatment and medical ecosystem within the country. Like our doctor here says, they can operate on more patients safely without needing to refer patients for blood. So by being able to provide more surgeries, they're able to provide as many patients as possible with top quality care.
Wake you up?
And the final anecdote, just to end, is one of the largest public hospitals in Nairobi. They see a heavy number of maternity cases, so both, complications such as ruptured ectopic and delivery. In her 2021 recap call to her fellow nursing managers, the theater in charge at this hospital reported that their maternal mortality numbers were 38, unfortunately, in 2020, but 11 in 2021. We all know there's a certain event that occurred during that time as well. And so when they asked her, what was the difference? What changed? She said, we started using hemofuse. I just want to end with that story there to talk a little bit about some of the impact that I've seen in my time living in Nairobi, supporting surgical teams, and where I believe that with continued adoption and scale, hemofuse can help to save more lives, help surgical teams to deliver the best care possible, and help healthcare systems that need to be as efficient as possible utilize every last drop of blood
her brother
available.
and sister
Thank
for the
you.
last half an hour. It's miserable.
Thank you for your attention,
She was up at
and I
4:45
hope that
this
you all
morning.
will join us in terms of trying to advocate for larger corporations, working with people who
Which
experience
one? What's Ollie's?
venture capitalism like Beth, and trying to figure out how to
All of them.
change the
Takes all of them.
paradigm
So
so
the
that both large
methylphenidate is
companies
the
and
one that
small
we're going up on.
companies can try to
Yep.
get
So this is
medical
the,
innovation for global health and try to get information about these
Yeah,
particular
exactly, but no, he
innovations
did- so
to the
yeah,
actual
that's the
people
old
who are
one.
working 365 days a year in low-resource
I'm
environments.
going to kill Millie. Can I do that, please?
These are the 2 new ones. It's this methylphenidate, but it's increased. So he gets 2 of these.
Yeah.
Excellent. It's been a really good beginning to
It's
this
until
day.
noon, but I think
Heard
there's going to
some
be a break, in
really
which case we'll.
critical messages. the reminder that there are people
we
out
play
there who are
video
solving
games?
for the
When
problems
I have a break, but
in their
not right
context,
now,
in their
okay?
communities.
After breakfast.
As mentioned by our friend
That's
Vajit Roy, it's good
Yeah, I'll do my
to
best.
hear from Minister Brophy, reminding us that it is critical, SOTA care is critical to fulfilling SDG 3 and many others. And we've heard some really strong reminders of when we try to solve for problems without real awareness of the context and the benefits of human-centered design, to look for the innovations that solve the needs of people without necessarily looking at people themselves and health as different products. Anyway, so for those of us who are here in Dublin, we have a bit of a chance to spend some time at the Collaboration Cafe and get a bit of lunch. Those of you who are joining us virtually, thank you for being with us. We ask you to please rejoin us in about an hour and a half, where we will continue with some really good panels. Thank you once again. We'll see you in an hour and a half.